So I'm speaking on evolution and management of blunt adnexal trauma and just give a brief of the guidelines. Now going into fracture management for the treatment of each type of orbital floor fracture, medial wall, lateral wall would probably be too extensive and beyond the scope of what we need as an overview, how to diagnose and how to refer the cases of trauma. So what I'm going to do is, I'll be excluding globe trauma because that's going to be spoken later. We'll talk about assessment evaluation, what are the imaging sequences that we need, and some special circumstances of how to screen and diagnose and points to keep in mind when you assess a patient with suspected orbital fracture, a retrobulbar hematoma, and what to do as the first step of management when you come across a patient with traumatic optic neuropathy. Hopefully we would not have the controversies that we had in glaucoma management here. The first thing is in case with any kind of trauma, and I stress on this because oftentimes patients with severe head injury are the ones who present with adnexal trauma, and in a lot of patients they are not in a coherent conscious condition. So it's important to make sure that just like we would do for tumors, so is the case for trauma. There is life salvage, then there is globe salvage, and then we look for vision salvage. Once the patient, an airway has been secured and the patient is stabilized with vitals being stable, we can then go on for concurrent treatment management for managing everything else. So general status, ocular status, rule out life-threatening emergency is then we go into the eye. So when we look for trauma, it's important to note the mode of trauma, the direction of the trauma, and the way in which it happened. Because that will help you to understand if there are other coexisting penetrating injuries or not. It's important to know the duration since trauma, because in a lot of cases the sequelae of trauma is evolving over time, how severe it is and how extent it is. So when we talk about the orbit, whenever in doubt, imaging is required. See, X-ray of the skull in any view, whether you call it a Waters view or heads-up view, paranasal sinus, is completely obsolete and does not aid in the management, diagnosis or management of any sort of bony trauma of the skull. CT scan is preferred because it helps you understand the bony anatomy and tells you exactly where the fracture is, or even if there is an intraorbital foreign body, if it is metallic, it will be better that visualized in CT scan, and obviously MRI is contraindicated in such a case, so you have to be absolutely sure that you do get a CT scan. When you are advising or requesting a CT scan in cases of trauma, ask for a CT scan of the orbit with 2 mm cuts, coronal and axial slices, and speak to the radiologist if they see a floor fracture, if they could send reconstructed parasagittal cuts as well. If you're suspecting traumatic optic neuropathy, you can even ask for 1.5 mm cuts at the orbital apex. So now you have a patient with a suspected fracture. What do you look for? Obviously, vision and pupils come in first. Ocular motility. It's important to know the motility because if there's an entrapment of a muscle, the action of that muscle would be limited. The action opposite of that muscle. For example, if the inferior rectus is entrapped, elevation is going to be restricted because the inferior rectus is going to be tethered at the fracture site. Palpate the orbital rim to check for a step deformity that tells you that the rim is involved in a fracture. Check for enophthalmos. If there is an entrapment along with prolapse of the orbital fat into the maxillary sinus, the eye does go into enophthalmos, and this is one of the things, like I mentioned, is a progressive condition that evolves over time. Enophthalmos worsens immediately after trauma and continues to worsen over time. Crepitus and emphysema. So crepitus is the palpable crepitus that you feel of air bubbles in the subcutaneous space, and emphysema is the air that enters there. So crepitus or emphysema occurs typically when there is a communication between the airway and the orbit. That will happen most typically in cases of a medial wall fracture where the ethmoidal sinus is breached and the patient sneezes loudly or forcefully. So you need to tell patients in suspected medial wall fractures as well not to sneeze or blow their nose. Trismus. Now when the patient is unable to open their mouth, you should always ask these patients to open their mouth and show how much their mouth opening is, because if there is a ZMZ, zygomatic or maxillocomplex fracture, they will be unable to open their mouth fully, and that will give you an idea that okay, there is a fracture and we need to refer. Infraorbital hyperesthesia. The division of the infraorbital nerve is a sensory nerve that goes right all the way up to the upper teeth. So the distribution of that nerve, you will feel that the patient will tell you that the sensations are much lesser on that side. All of these have to be documented while evaluating a patient of this. So what is this? Can someone just, one of the residents, if they know what is this, what is the halo sign? CSF. So that's right. So in a suspected NOE or naso-orbitoethmoidal fracture or fracture of the cribriform plate of the ethmoid, patient may have some sort of bleeding from the nose. You put in a Whatman filter paper or even a plain white muslin cloth and you will see two rings. The first ring is the ring of diffusion of the blood and the heme in the blood. The second, because CSF is much less viscous than blood, it diffuses and spreads out more. So if you see two rings compared to just one ring of blood, this is indicative of CSF and that requires an immediate treatment. So getting especially in patients, you also can get this from the ear. Patients with petrous or temporal bone fractures can also have CSF coming from the ear. So rhinorrhea and otorrhea, whatever is the content, should be checked for presence of CSF. Now broadly, without going into the details, orbital fractures can be classified as simple and complex. Simples are ones that involve only one bone or one wall. Complex typically involve the rim as well as multiple bones. A blowout fracture is the most commonest and it presents first to the ophthalmologist because the posteromedial wall is the thinnest wall of all the orbit walls. You can see up gaze will be restricted. So now you've done a CT scan, you've identified that there is a fracture, you're unsure if there is an entrapment or not. So there are some clear guidelines on what are actual indications for repair in a case of blowout fracture. If there is clear entrapment with motility restriction, in children if there is a triggered oculocardiac reflex, if patient has diplopia not just in primary and down gaze but in all gazes, gross enophthalmos and late enophthalmos are relative indications for surgery. So in complex fractures where you think there is a zygomatico maxillary complex fracture, it's actually not a tripod, it's now called a tetrapod fracture. This is what you can request the radiologist for, which is a 3D reconstructed scan. So that can give you an exact topography of where the fracture is. So from the fracture, we'll come to the soft tissue. Retrobulbar hematoma can also occur in cases of blunt trauma. And in these cases, it is basically an acute orbital compartment syndrome. The blood gets accumulated there. There is no space to go and it progressively goes on increasing. Pain, RAPD, proptosis, ophthalmoplegia and reducing vision or IOP more than 40 mmHg that presents to you in an emergent condition. A lateral canthotomy and cantholysis are extremely urgently to be performed. Subperiosteal hematoma can present like this. The scan below, the parasagittal scan, is the classical appearance of a subperiosteal hematoma. You can see the fluid collection in the subperiosteal space. Indications for intervention, which would mean a needle, pushing in a needle through that space and aspirating, would be diplopia that persists, motility restriction, reduced vision or gross choroidal folds. So in these cases, you want to aspirate. I'll quickly cover my last topic, which is traumatic optic neuropathy, which can either be because of direct avulsion, direct trauma, or indirect trauma. A quick show of hands. Traumatic optic neuropathy, patients with counting has a blunt trauma. A CT scan done shows no bony impingement on the optic nerve. Vision is counting fingers, 30-year-old male. How many would give steroids or IVMP, IV methylprednisolone steroids at presentation? Show of hands. Okay, how many of you all will not give steroids? So just 4 people will not give steroids. All right. So the investigator of the first study that studied the effect of steroids on traumatic optic neuropathy, they used a rat model where they used a rat to create artificial, simulate the crush trauma, was Dr. Kenneth Steen-Sapir. And in this very telling commentary he wrote couple of years ago in the IGO for a review on traumatic optic neuropathy, he concludes, so this is the author who first recommended megadose steroids. He says, the study and all the data that they have, so he's the one who wrote the IONTS, the International Optic Nerve Study, said that that it does not imply in any way that corticosteroids are useful for treating traumatic optic neuropathy unless there is new experimental data that defines a role for high-dose steroids. Their use in the treatment of traumatic optic neuropathy should be abandoned. I don't think there's any more conclusive evidence. There is unfortunately no class 1 evidence to show traumatic neuropathy improves with steroids. So I think more than the patient, it is for the operating surgeon or the treating physician that we are giving steroids. Just one note is traumatic ptosis. If you have a case of blunt trauma, observation is the best thing to do. Time is your best friend in these cases. So to summarize, systemic, we always go triage systemically, periocular and then periocular. In cases of orbital trauma, image immediately, which is CT scan, your choice of imaging. Traumatic ptosis is something you can wait and watch for 6 months, because in these cases, time really is your best friend. I'd like to thank you for your time.
Thank you. That was a very good carry-home message for all of us, and especially for general ophthalmologists with regard to what they should look for in case of a blunt trauma in the region of the globe and around. So,
sir, I have one question to Akshay. You
After the
repeat the
conference,
question.
I'll tell you.
Repeat the question.
Whose skull was it that got punched on top? So I said, I'll tell him after the conference. No, they're just showing how blunt trauma most commonly occurs is actually a punch, which accounts for more than half of all blunt traumas in the eye.
Especially if there are strong men doing it.
Sir?
Especially if strong men
Strong.
do it. Okay, Jayant.
Akshay, you are mentioning that is in a rabbit, it was a crash. That it may be a direct crash, so there may not be edema. I want to just say a point, but in our orbital trauma, there is a lots of diffuse edema all around surrounding. It may not be that role of advocacy for steroids, there is no such harm until unless there is an intracranial injury.
Right.
Of course, there is an intracranial injury. We should not start any IV methylprednisolone. But once the physician is concerned, as there is so many points regarding moment, if you observe the CT scan or MRI, there is a surrounding inflammation, not only the optic nerve. So that steroid probably may help on such patient where there is a edema which may hamper the vascular supply further.
Sure.
So in such scenario, we can assess and accordingly.
Right, I agree with you even, and my hand was also up when I said steroids in traumatic optic.
So I think the reason is that if you don't, he'll go to another person.
Correct.
He'll be dissatisfied with you. He'll give him IV steroid, and he will blame you for not.
And not only that, whatever vision which would have come across,
so since
because
there's
of
no evidence to say that it is pakka evidence at this moment to say that nahi dena chahiye, so I think most people would give it.
And even in traumatic optic neuropathy, almost a third of patients have some spontaneous recovery of vision, which then they will attribute to the steroids anyways.
So I think just 3 carry-home messages mainly. Have a high index of suspicion for 1, orbital fractures, 2 possible canalicular injuries as well, and 3rd even a trauma involving eyelids with even a marginal cut or a laceration or a laceration which needs repair. So look for all of them.
And actually just one more point, if we do a CT scan in traumatic optic neuropathy and we don't find a bony fragment impinging, but still doesn't account for the vision loss, we can do an MRI with contrast, because in those cases you may actually see an intra-sheath hematoma, which then would be an indication for urgent decompression.
So I think the fact remains that surgical intervention is needed in a minuscule number of cases of optic neuropathy. And the definitive indications are only a definite compression shown, either bony or a hematoma, or a progression which was actually documented, that the vision is dropping from say 636 to 260 or something. So those are the 2 definitive indications. Otherwise, as of today, there are no indications, and they're all indications for you to run away for your flight.
Yes.
And you can add that there should not be nose blowing whenever
Yes.
it's a thing, so that for general ophthalmologists we should
Absolutely.
say that. And the thing when you say that
True.
So for that, we have developed the algorithm for this
Dynamic
flap tear,
MRI.
and that can work very well. And
Great. Thank you so much.
Dr. Prashant,